first, a hand poll. Just raise your hand if you are a natural skeptic. That's all I want to see. Who are the natural skeptics in the room? Okay, great. Now, who are the people that, after seeing the evidence today and hearing about this, have some mild excitement? And who are the folks that are like really excited? Does anybody say, okay, this is excellent, okay. Because I'm kind of all of those people, right? I, as a pathophysiology professor, as a person living with obesity, and as a clinic director of an obesity clinic, I move from skepticism to endorsement pretty slowly because I have had all the side effects of orlistat, and most of them publicly. So, yeah, it's you don't want to be that guy. So today we're going to look at how do I move from skepticism really into how do we get this into the clinic, right? So yes, I have two endorsements. I try to shy away from these things, but this is my movement from skepticism to into endorsement. And today is really going to be what I do in the integration science side. How do we move this idea into clinical practice, especially when it meets a gap? So when we look at potential candidates, well, what I did was talk to patients in my clinic and my students because I like to vet these things with people that I know. And I do the what about something like this. Because as a person living with obesity, I traveled with a refrigerated bag of meds and they wanted to upgrade my room for $40 a night to get a refrigerator. So I don't think the epitome people are noticing this right now, right? Okay, just we'll disregard they didn't see this, right? But the idea here is that the convenience factor is what many of my patients said. They have to be over 18, and if you're normal glycemic or prediabetes, a good candidate. But the thing that I loved about the ethos of the company is that they really endorse lifestyle, and that's something big in my practice. My clinic looks like a little fitness center. I cook with my patients. I eat with my patients. I dance with them. We work out. I have a 90-year-old patient that can deadlift 90 pounds. Like, yeah, this is awesome. So the lifestyle part, the fact that they take it seriously meant a lot for me. The idea that you probably see patients every day who say, is there anything that's non-surgical that I could consider first? Anybody have those patients? I'm just curious. Well, that's most of the hands. All right. So when we look at this, especially with the consistency of results across ages and genders, I get excited. Let's look at what some of my patients are saying. 48-year-old Emily, she's a teacher. She comes to me because of a problem she perceives on the scale. And she talks about hormonal hunger because she is going nuts. As she said, this last year with hormonal changes and her PCP didn't address that. So guess what the obesity guy does? Talks about HRT, and we start treating her perimenopausal symptoms because that was driving her, as she said, nuts. She was on HCTZ reluctantly from her PCP, and she said, if there's any way I can get off this, I want to. Is there something I can do? So we talked about obesity and obesity-related conditions and how treating her obesity would be an excellent way to treat all of her concerns. And then when she asked about this, I said, well, let me ask you, if something like this was available, and she says, oh my goodness, yes. When do I get it? Where do I get it? How do I get it? So her enthusiasm kind of buoyed my interest. And why would she fit? Well, when we look at the efficacy profile that's we see in the reset data and the early response, plus her motivation, plus the hormonal hunger that she's experiencing, we can see some great benefit potential for her. And an expectation that given all of these things, she could have a 6.6 to 9.3% reduction in total body weight. And so guess what she is? Calling me once a week, using the patient portal. Is it ready yet? Is it ready yet? Is it ready yet? So hopefully it will be ready soon. John's a 48-year-old male. He's a truck driver. He drives across the country. So for him to carry meds inside his truck's now a feasible thing. So he's a great subset, especially given that he has prediabetes and he has dyslipidemia. Looking at the data, especially when you look at those HOMA-IR scales and the insulin reductions, great candidate, especially with the efficacy across genders, right? So same thing, we're going to have some risk reversal potential for him, but we're also going to improve the quality of life because driving a truck across country and dragging all those other things, that's a challenge. I deal with a lot of people trying to get in the military. Do you know one of the number one reasons people cannot get into the military right now is obesity? So I work with a cohort of patients who cannot be on medications and they have to achieve certain goals before they get in. Alex is one of them with a BMI of 28. Isn't it great that the indication for this is 25? Exciting. This fits his need because one, he's motivated to do the lifestyle side. Two, he doesn't want a medicine. In fact, he says, I cannot be on a medicine, but he also aligns with that normal glycemic group. And then there's Sarah, one of our students. She's a PhD student, and she said, the freshman 15, well, I've got the PhD 15. And it's not from the best eating habits. She's getting ready to defend soon, so she is just nervous and eating all the time. And she has a history of type 2 diabetes. She said, my mom got diabetes about 10 years after she finished her PhD program. I don't want to be there. She wants to halt the weight gain, but she doesn't want to use medications. She wants to keep with her lifestyle. And I talked to her about Epitome, and she said, wow, is it available yet? Question you probably are all asking yourselves. But she'd be a great fit because this addressed some of that stress hunger. This is going to improve that sense of satiety, and that would help her not be snacking between meals, which she said was one of the biggest things that she's facing. And she perceives the benefit of a non-pharmacologic agent because culturally, for her, that's very important. But the idea here is that based on the evidence supporting the use of these capsules, we have a broad category of patients. Do you guys have, based on what we've talked and what I've illustrated, how many of you right now have at least one patient in mind who this would be a fit? Just curious. So the idea here is when you have this think about the safety risk profile. Think about the mechanism. Think about the relative limited amount of contraindications and relevant precautions, and that we can use this with coexisting cardiometabolic conditions. These are all wins for the patients that I serve, and most likely the patients you serve. So thank you for your time.